Hello, I'm Dr. Femi. In this ENT bootcamp, I'd like to introduce us to the basics of ENT. Also, I will be talking about Komot and Naira Palm. They are mnemonics that I developed for the causes of sensorineural and conductive hearing loss. Brief anatomy: the ear is divided into the outer, the middle, and the inner parts. Now, the pinna on the outer part, it serves as the antenna that receives sound waves, pass it through the middle ear, that's where the ossicles are lodged for onward transmission into the inner ear, and the sound is eventually interpreted by the brain. Now, for any reason where the sounds cannot reach the inner ear, maybe as a result of blockade in the outer or middle ear, it results in conductive hearing loss. Whereas if there is a primary problem in the inner ear, maybe with the nerves, the auditory nerve, the cochlear nerve, then we have what we call the sensorineural loss. There is diseases of the middle ear. The mnemonic is Komot. I will introduce you to this. Then obstruction of the auditory canal can also cause conduction hearing loss. Inner ear, the causes of sensorineural hearing loss include Naira Palm. We will meet these later in this series. Then damage to the cochlear nerve. The Rene and Weber tests, they are important tools for differentiating between conductive hearing loss and sensorineural hearing loss. The Rene test, it allows the comparison of ear to bone conduction. The method, you place a vibrating tuning fork against the mastoid process. When the patient stops hearing the sound, you place this fork next to the patient ear. The sound wave is now conducted by air. Now, normally, air condition is better than bank charges. AC is greater than BC. Air conduction is greater than bone conduction. That is the basis of a Rene test. Now, whenever BC is greater than AC, you have a form of what? Conduction hearing loss. That's the interpretation. AC greater than BC. When BC is greater than AC, the Rene test is negative and there is conduction deafness. Weber test, simple to perform. A vibrating tuning fork, you place it on the middle of your head and the vibration should be felt equally in both ears. When felt equally, we say there is no lateralization. Example now. Rene test, AC greater than BC. This is a positive Rene test and this is normal. Weber test, non-lateralization. This is normal finding, or in maybe bilateral sensorineural hearing loss. Rene, AC greater than BC, Weber lateralization to the left. AC greater than BC means this is normal. Lateralization of sound on Weber to the left. There is no conduction hearing loss. That means the right ear is not picking the sounds properly as a result of primary problem in the inner ear. So this is right sensorineural hearing loss. Example 3, there is a positive, Rene test is positive on the left but negative on the right. Now, what is positive Rene? AC is greater than BC. Negative Rene, BC greater than AC. So the right part of the air has a form of conduction hearing loss. That's the Rene interpretation. Weber interpretation, there's lateralization to the right. So in the right here has conduction deafness from Rene. And for it to lateralize to the right, there's this explanation when there is blockage of the middle ear, there's an upregulation of the sensitivity of that air. So sounds that goes into that place, they appear louder. Also, because of the blockage, the sound is trapped. That's the sound that travel through the bone into the inner ear, they are trapped because of the blockade, and that still enhance the loudness. That's the pathophysiology of it, but this is what we have. So you can take time, study this slide. This is the overview of the Rene and Weber test. Causes of conductive hearing loss, we have commot, cholesteatoma, otosclerosis, malignant otitis media effusion, and tympanosclerosis. Sensorineural hearing loss, we have neuropathy. That's the causes now. Diseases that lead to sensorineural hearing loss. Diseases of the inner ear that leads to sensorineural hearing loss. We have noise-induced hearing loss, presbyacusis, acoustic neuroma, labyrinthitis, and Meniere's disease. Otitis media effusion. Common cause of otitis media effusion in Plab, they will paint a picture of a child. A child who has a form of deafness or who sits in front of TV, a loud TV, the patient needs to scream to reach him, or who is doing poorly in school. All these pointing towards deafness. Then otoscopy will show retracted or bulging membrane with air fluid level because of fluid within the membrane. Then when you suspect otitis media effusion in a child, do a pure tone audiometry first. Then for treatment, the first thing you do is to reassure, because this can resolve spontaneously. And you advise parents to stop smoking within the household, as smoking is an important causal agent. Then you give a 3-month appointment. When they return after 3 months and the complaints persist, you insert a grommet. A grommet is a material you place on the tympanic membrane and allows the fluid that is accumulating within the membrane to leak out. If surgery is rejected, then you can give hearing aids. Otosclerosis. Now, while otitis media effusion is commoner in children, otosclerosis is in young adults 15 to 45. Pregnancy exacerbates the condition. 50% family history, male-female ratio of 1 to 2. Otoscopy may be normal, or we have the Schwartz sign, which is the flamingo blue blush. Treatment, no cure, but you can manage the condition by removing the stapes. Presbyacusis. Plab will paint a picture of an elderly man who believes he is alright, but is actually deaf, always, and will be complaining, why are you shouting, why are you shouting? You have to scream for him to get your gist. And when you scream, the man will be shouting, why are you shouting? So they bring this guy in, suspecting presbyacusis is a degenerative change, as a result of degenerative changes in the inner. Then we have tympanosclerosis, that we have a chalky white deposit on the tympanic membrane. I place these two together, the tympanosclerosis and cholesteatoma, because Tympanosclerosis has this chalky white mass on the tympanum, while cholesteatoma has a poly white mass behind the tympanic membrane. Now you can use tack and cap. Tack cap. Tympanosclerosis has a chalky white. Tympanosclerosis has a chalky white on the tympanum, where cholesteatoma has a poly white mass behind the tympanum. Meniere's disease, a patient has a progressive deafness, vertigo, tinnitus, complaints of fullness of the air. There may be nausea or vomiting. Lasts for a few minutes. The treatment is propofol. Acoustic neuroma, just like your Meniere's disease, but there is nerve involvement. Maybe the Plab may paint a story of a man with deafness, with vertigo, and has evidence of facial nerve palsy, or you may have this that he has diplopia. Then you'll be thinking of acoustic neuroma. And an important investigation that you do to differentiate the two, you do MRI. So if the patient has a sensorineural hearing loss or reading and Weber test, order for MRI. For acoustic neuroma, there is a benign mass on the cerebellopontine angle. This is absent for Meniere's disease. Then vestibular neuritis is another important disease. It has the 3V, the vertigo, vomiting, and there is a previous or recent history of viral upper respiratory tract infection. If you have only these three, you think of vestibular neuritis. While if you have the 3Vs, the vertigo, vomiting, and the viral upper respiratory tract, that's a previous history of the disease, and this person has what? Deafness or with tinnitus. That's the difference. So you know which one to pick. Finally, we'll talk about the benign paroxysmal positional vertigo. Now, the scenario that will be painted is of a young or an adult that wakes up and the whole place starts turning. Every time he tries to move, the place will be turning. It lasts for a few minutes and resolves spontaneously. Your mind should go to the benign paroxysmal positional vertigo. Now, for your diagnosis, you do a Dix all-pikes maneuver, DIX, all-pikes maneuver, D to D. Then the treatment is by the place maneuver, where you try to reposition the calcium material within the posterior semicircular canal. Thank you for listening. I hope that you learned something. Cheers all.